Welcome everyone to today's webinar, Enhancing RCM at the Point of Conversation, Insights from Corwell Health, Riverside, and Dayton Children's. Before we begin, I'll walk us through just a few quick housekeeping notes. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. And if at any time you have issues with the audio or visual, please try refreshing your browser. You can also submit any technical questions into the Q&A box, and we're here to help. It's now my pleasure to turn the floor over to our presenters today to dive into the discussion.
Hi, everyone. Thanks for tuning in today and welcome to our webinar, Enhancing RCM at the Point of Conversation, Insights from Corwell Health, Riverside, and Dayton Children's. I'm Sagar Sanghvi, CFO at Bridge. Today, we'll hear from our panelists about how AI-powered documentation is driving revenue transformation, from early adoption to measurable outcomes to what's ahead. I'll turn it over to our speakers to introduce themselves now. Dr. Frazier, would you like to kick us off?
Sure. Hi, everybody. My name is Charlie Frazier. I'm a family physician, and I'm the Chief Medical Information and Innovation Officer at Riverside Health. Riverside Health is a integrated health system in Eastern Virginia. So thanks for having me.
Chris, you want to go next?
Sure. Hi, Sagar. Chris Bergman, Chief Financial Officer at Dayton Children's Hospital. We are a small children's hospital located in Dayton, Ohio. And like I said, I'm the Chief Financial Officer. I also have responsibilities for IT as well as normal finance functions.
Thanks, Chris. Matt, I'll kick it over to you.
Great. Matt Cox. I am the Chief Financial Officer for Corwell Health. We're a large integrated delivery system in Michigan. We've got 21 hospitals, a large integrated health plan with 1.3 million members. Overall, we're about $16 billion in revenue and over 60,000 employees.
Amazing. Thank you. Thank you to all three of you for joining us today. Dr. Frazier, I'd love to start with you. In your role as Chief Innovation Officer, what transformation goals were you targeting when your team decided to implement AI-powered clinical documentation?
Well, I think we were just trying to make it easier for providers. I've been doing informatics for 30 years, and I always believed that if you use a computer to document the care that you were providing to patients, you could actually use that data to take better care of them. And I think that's borne out to be true. The problem with that, though, is a lot of that data that you need to make some of that impact. I mean, it takes a lot of documentation, and that's gotten worse over the decades. And so you put data points in the note to capture data to prove that what you're doing, or, you have to, add a bunch of stuff to your note so that you can get paid. And it has become quite burdensome. I know as a family physician, when I'm seeing patients, I almost feel like I'm an air traffic controller. I mean, you have patients come in and they have 5 and 6 and 7 and 8, issues, and you're trying to help them prioritize what you're working on during that visit, and then you have to listen to that, and you have to think about what's going on and make your assessment, and then you have to formulate a plan, and on top of all that, you have to document it, and you have to document it well, and it's a lot. And so I think the holy grail for us, even with, you had voice recognition, but I think the holy grail was really like, could we have something that actually listened to that conversation and did documentation in a way that made sense, and it captured the information that you need, and let you, take that off of your plate. And, we kept looking for that. And finally, as generative AI came around a few years ago, Bridge and some others, maybe we're getting close. And for us, I mean, we were really looking for a platform that was, as fully integrated with our electronic health record as we could. So we looked at a Bridge and one other, and really we liked a Bridge because for a couple of reasons. Number one, the large language model was proprietary and it was trained on medical notes. But the other thing was we just liked, we liked the Bridge CEO. We liked the vision. We liked, kind of the way you guys looked at things. So we started a pilot a year ago in May, and it's been very successful for us. And I look forward to telling you a little bit more about the outcomes we received. maybe the most important, which is that the providers love it. So, but I'll tell you more about that.
Well, we appreciate your partnership, and I think, from a patient provider experience standpoint, we hear the love stories every day, right? And we see it and we feel it as patients ourselves. But I'll kick it over to Matt and Chris, because the CFO perspective is a different perspective than it feels good for providers and patients. And I'd love to hear from you guys. What made generative AI compelling to explore, even when in the early days our ROI was a bit more qualitative? What were the pain points you were trying to address, and how did you come to that decision? Chris, maybe I'll start with you.
Yeah, I think that goes back, even for us, our journey starts 5, 6 years ago when we changed how we even approached some of our IT functionality, and how we created a group that sat between the providers and the IT to say, how do we translate what the needs are and get the most out of our EMR? And so we made a lot of progress from that perspective to help with workflows and get data put where they need to be. And we've continued we're a small children's hospital located between two large, really highly rated children's hospitals. So we have to be really sharp if we want to attract the best, the brightest, and keep the best physicians we can in our organization. So we're always constantly looking for how do we make their flow better. So even to the point where we had great satisfaction scores from our physicians on our EMR, although they're not great, they just happen to be highly ranked compared to other people. Not that the bar is very high. I always kind of chuckle about things like that. So then we continue to advance forward. We have the joy of medicine. What's our burnout rate? What are our satisfaction? What do people want to look for? What's their biggest pain point? And you get down to it's all the time they spend on the chart. The EMR is not just that intuitive to use. I don't get to spend time talking to my patients. I'm looking at my computer. So you have a problem statement, you're trying to solve it. And that's where the generative AI, I think, really helped us do it. We've tried to maintain from our side that we have a problem to solve, and how does technology help solve it, versus we create a problem statement around some new technology, because that's, we got to make sure we stay on course with what we're trying to do. And so as we looked at it, it seemed like it was some of those soft costs that I know CFOs don't always like, the soft cost savings, but it's really about how do I continue to recruit, retain, and keep our provider group from starting to suffer all the burnout that is going on out there with all the things that they have to use.
I love that, Chris. And I'd love to double click on some of those outcomes that you're seeing already. But Matt, maybe I'll kick it over to you first on what you guys were looking for.
Yeah, I think Chris summed it up pretty well, and it's really not that different at Corwell. So we started looking at it primarily as a way to reduce burnout. And reducing burnout is costly, so it is a financial issue. So we did a small pilot, and it took us a long time. We built a business plan that wrapped around it. And ultimately, I think it's been a great investment for us. So what's something that started out mainly focused on helping us increase access and reduce physician burnout, which it's absolutely done those things. But it's also helped us really pay for itself. So when we look at some of the metrics that I track, we track our work reviews very closely, and where we've implemented a bridge, we can see that our work reviews are up 11%. That's overall. So, I mean, an 11% increase in work review, that's a significant increase. That's not, that's something that's measurable, and it has a defined ROI. So when we look at it that way, we also look at how many more patients can our physicians see just from an access perspective. It's so hard for people to get in to see their physicians. It's hard. There's not appointments that are available. What we're seeing once we've implemented a bridge, on average, it's a 2.2% or 2.2 additional appointments per week per provider, which is great from an access perspective. Documentation's better, 14% decrease in times and notes per day. So we've really focused on how do we measure everything so that we can quantitatively come back and say, did this work or did it not work? And overall, what we're saying right now is that this is a great program. It's working the best in primary care. I mean, it's where everybody's banging on our door. If they don't have it, they want it from a provider perspective. But we're seeing that we're having great adoption. So in fact, 90% of our clinicians that have used it still use it. So when you think about new tools that have come out, 90% retention rate is great.
Yeah, we're really proud of that case study and those data points, and it's what we're hearing from a lot of our partners. Dr. Fraser, I'd love to kick it over to you because I think you've seen a similar impact at Riverside. Maybe you could touch a little bit on the measurable outcomes you've seen.
Yeah, it's interesting. What we've seen is so very close to what Matt just talked about. So, regarding burnout in our pilot, we did a survey before they started, and then we did another survey 30 days. And I kind of wish we'd continued doing that, but we did it during the pilot. And 61% of our providers in that pilot, had some degree of burnout before they started, and 30 days in, it dropped down to 27.7%. So, that 61%, that's pretty close to what you see nationally. So that's what really, for our leadership, really kind of sold it into the leadership of the group and the health system. To their credit, they said, we just need to do this. That's amazing. We need to do that. So again, that's why we were doing it, as a provider experience. But the things we've seen in addition to that it's pretty impressive. So we saw a same sort of thing. We saw a 15% decrease in time and notes in that activity within electronic health record per day, a 17% decrease in time and notes per encounter. We didn't see as big of a decrease as I thought we would in what we call pajama time, or working in an electronic health record at night or on weekends. But that went down 7%. And then in talking to my colleagues, what we find is that they're using that time differently. They still have the flexibility that, if they need to get off work and go to their kid's soccer game or something, they could do that. But they, when they are working at night, the notes are done. So now they're actually, prepping their charts for the next day. And they think that actually improves the care they're providing, because they're up, they're more up to on that patient's history and care, and reminding themselves of that. We found that the amount of time that the patient waits in the room from the time after they get checked in by the rooming staff to when the physician or the provider comes in, that decreased by 2 minutes. And that doesn't sound like a lot, but that adds up, throughout the day, adds up to a lot. And I think some of that decrease in wait time, and the fact that then the provider is looking at the patient and they're paying attention to the patient. I mean, we used to hear all the time, too many times, the provider paid more attention to the computer than they did to me. Well, they don't have that now. They're looking at the patient. So some of the patient experience stuff that we saw, like if we looked at our top box scores, which were pretty high. This again was in the pilot group, but like 84.8% of the time they're in the top box overall, and that went up almost 3 percentage points to 87.6. And I'll be honest with you, I'm just a doc. I was like, that only went up 3 percentage points. But the president of the medical group was ecstatic. She said, Dr. Fraser, do you understand how hard it is when you're that high to get it up another 3 percentage points? She said, that's amazing. So the patients like it too. And then of course, I kind of mentioned it already, but the voicemails I've received, the emails, again, as the CMIO, for decades, the emails I get from providers are generally like, this sucks, this upgrade is killing us, or we implement something new. This is a complete and utter disaster. I mean, negative emails. But with this, the emails I get are, I save them all. It's like game changing, life changing, practice changing, magical. I save them because I'm not used to getting emails like that. In fact, I got one Saturday morning. I showed it to my wife because it really brought tears to my eyes. I got one from a provider, and that person said, I didn't want to out myself, but I have dyslexia, basically what they said. And they said, you wouldn't believe how much time I spend correcting the squiggly lines in my notes. And this person started this on Tuesday. This is Saturday. And they said, when I got done seeing patients yesterday, I was done. Yeah. And said, this is the first Saturday morning forever that I hadn't been sitting here working on my charts. And when I go out to my son's soccer game this morning, I'm going to enjoy myself so much. You have changed my life. That's the kind of impact this is having on providers. And then there's the revenue cycle side of it. So one of the things we saw right from the beginning, I noticed it myself and my colleagues said the same thing, is that, by the way, one of the things we make them agree to is that they have to review every single note. They have to review the whole thing because it's great, but it's still new.
Yeah.
And sometimes it'll make a little mistake or it'll get things confused, like when you have a husband and wife in there, and sometimes it gets a little mixed up with what goes with who, right? And so you have to review that note. But what we found was that you go through there and go, oh yeah, that's right. We talked about their COPD, and oh yeah, we talked about this. And so you end up putting more diagnoses in there, whereas before you kind of had the top 3 or 4 top of mind, even though you actually discussed other things, particularly the ones where they're stable and and you're going to continue the regimen and that sort of thing. Well, when you complete that documentation like that, for example, we saw that on average, the number of diagnoses entered per encounter went up 15%, which on an average, I mean, you're talking, partial numbers, right? But over a big number of encounters, that's huge. The number of HCC diagnoses, those ones that are so important for risk adjustment factor analyses and value-based arrangements, and our Medicare and Medicare Advantage patients went up 14%. So, and what that actually does is every so often that actually shifts that evaluation and management code up to the next level. So what we found was, and this was, this is not just a pilot, but after we rolled it out to, dozens and dozens and dozens of more providers, that for new patients, for example, the proportion of level 5 visits went up by 5 percentage points. And those are smaller numbers, but in the established patients where you have the big numbers, the level 4 visits, the proportion of those went up 4 percentage points. I'm not talking about relative increase. I'm talking 4 full percentage points. And that matches, just like Matt was saying, what we saw in the pilot. I kind of don't calculate this so much anymore, but our work RVUs also went up 11% in the pilot. So, and then we also looked at, because we know the exact date all these providers started using the bridge, and we actually, I couldn't do this, it was above my pay grade, but had our business intelligence folks do this. But we calculated net revenue, and that went up significantly after they started per encounter. Net revenue went up after they started using a bridge, to the point that it more than paid for a bridge, a factor of 2. And that was with the original rates. And of course, with volume and some of the subscription costs go down, I'm looking, that's probably going to be a 4-time return on investment. So, and then with our panel discussion that we had, I was struggling to try to figure out how to analyze the impact on volume, because if you try to do it on a daily basis, their schedules all changes and everything. So I think it was Matt, or maybe it was Chris, but one of them talked about I think it was Matt talking about looking at the weekly encounters. And so looking back at our established providers, those providers who have been seeing patients when we started Bridge at least 2 years, because you have new people, of course, they're building their practice. But these established providers, their weekly number of encounters went up 7.9%. So, so not only are you increasing the E&M codes and the net revenue per encounter, but you're having more encounters. And so, so the revenue cycle side of it is really looking good for us as well.
Well, I love that. I mean, the qualitative stuff, and we should debate whether CFOs or CMIOs get more negative emails every week. But I think we both see them, which obviously is why we're in it, to hear those love stories. But the quantitative side matters so much. It's our goal as a CFO myself to make your businesses better through our technology and make it easier for you guys to generate return. And Chris and I have talked about this at length before as well. So thank you for sharing that, Dr. Frazier. I want to jump ahead because I know we only have a few minutes left here. Chris, maybe I'll kick it over to you. Looking ahead, when you see what we've done with AI-powered documentation, where do you see it transforming RevCycle in the next 2, 3, 4, 5 years?
I think for us, one thing I keep looking at is, it's hard to find good coders to begin with. And so coding is everything in the RevCycle world. and making sure you capture the documentation to the actual coding and the billing. And we can do it. We can hire the people to cover the inpatient side, the clinic volume, high volume, low dollars. It's really hard to devote a lot of people personal time to those pieces. And so we tend to kind of do more like get a new provider up to speed and then maybe go back and spot check them occasionally. But we don't know what they're doing on a day-to-day basis when it comes to picking E&M codes, et cetera, et cetera. So to me, I view this as it's a really great way. I mean, I need to get some automated coding going, which I might be able to do through my EMR, but I also got to have a better documentation plan. I can use my CDI group to focus on my inpatient business and maybe some of the higher dollar claims, but this high volume, low dollar volume is really always hard to like get your hands around. And so that if you could probably find a 10% lift in those things if you could just focus on it. So I think of this from a revenue cycle perspective as one, we went into it with the right reason, which was we really needed to give our physicians something. We have physicians say, we haven't had any good technology since the EMR came out that actually helped our life. And this is the first one we've had that's actually helped our life be better. And that, to me, that says it all. It's like finally you actually invested in something that the physicians are actually saying, man, this is really good. This is the first one you've given me. We all get excited about giving new technology and it doesn't really help their job at all. And now this one does. So you go into it with the right reason, but you also know there's that extra piece, which is if I can improve my documentation, improve my coding on that high volume stuff, you're going to get a yield off of it. I think the next phase, quite honestly, is on the nursing side. I just think up on the inpatient floors and also the nursing would be really beneficial to have some automated, some AI-enabled documentation for them. They spend an awful lot of time in the chart. They spend an awful lot of time with the patient. If there was an ability for them to do the same sort of documentation, I know there's nuances there and there's lots of complications, but that would be a huge part where you've got all your nurses working 24/7 constantly in the record. If you could help them with their documentation, I can't help it. That would improve a lot, not only in their work-life balance, but just, the whole improvement of the documentation side, in terms of how you hand it off from person to person, et cetera, et cetera. I think it just improves safety of care and all those different pieces. So I don't know. I look at it. I always do the back end to it. It's like if I could see one more patient a week, and I'm glad that Matt's saying they're up 2.2. We're just kind of early on the full rollout to our first phase of physicians. We did our trial. We're in our first rollout of a smaller group of physicians. But if we can get 2.2 patients more per week, I mean, we're looking at break even of about a patient a week, maybe even a little bit less than that. And so I think that makes total sense, and I'm glad to see that guys like Matt are already seeing that kind of improvement, on a weekly basis with their volume. So that's where I see it for both the revenue cycles, volume, and it's actually just getting paid better per claim. The payers aren't looking to pay us more tomorrow than they are paying us today, so we got to do everything we can to stay on top of that.
Yeah, we want to help you guys be accurate in your documentation to make sure we're paid for the care we deliver, as we like to say. And thank you for the plug on nursing. We're excited about rolling that product out over the next 12 months. Matt, I'd love to hear where you see RCM and AI powered documentation going.
Great. I think that AI is going to play a huge role in revenue cycle over the next few years. Historically, revenue cycle has been very people focused. We have coders, we have billers, we have clinical documentation improvement specialists. We've got all of these people that are very focused on making the revenue cycle work and work well. Yeah. Now we have really great electronic medical records like Epic. We have one instance of Epic across all of our hospitals. So we've got this great infrastructure. So we can use platforms like a Bridge to come in and help us really just unleash the capabilities of those systems. And I think about where there's opportunity. Certainly nursing, I think, is a huge opportunity. There's a lot of documentation that happens there. And we've got to get the documentation right to get the bills right. But I also think about, all the positions that have been offshored over the years. All of those are ripe for automation and ripe for AI. And I think that there's going to be a huge opportunity there for us to lower our costs and make things simpler and better by embracing some of these tools. I too, get emails from providers from time to time, and I just want to go back to that for a minute. This is one of those rare tools or platforms that we've put in where we're getting just absolute positive feedback all the time. And the ones that relate directly to the rev cycle, I got a quote here, it's drastically improved my documentation and given me more time during the day. That's from a physician. It's been nice to have to come home and write notes every single night. That's from a physician. This improves the quality of my notes by 200%. Those are all real quotes from our physicians that all directly impact the revenue cycle and our ability to fund our mission.
Yeah.
Thank you so much. I mean, the quotes always, when we're in it on our side, trying to build the technology and working hard, those are the lifeblood of our organization too. And we're so glad you shared those with us. Well,
Hey, Sagar, one thing I was going to say is that even though Charlie says he's getting a 4-to-1 return, it doesn't mean that you can raise your price. I mean, we're paying enough. No, I'm just kidding. But we actually, one of our physicians back to the quote says, I consider a bridge my Christmas gift from DCH. So I was giving the guys a hard time when we were in Denver that I can save on Christmas hams and turkeys now because we gave them a bridge instead. So.
Well, we'll talk about pricing. Chris, we aim to please, so we'll always do what we can to make sure we're delivering really good ROI. I want to thank you guys again for joining us, and a lot of gratitude and appreciation for me to get insights from the three of you on this panel. To our listeners, we hope this conversation helps guide you as you explore the future of AI and clinical documentation and rev cycle. And with that, we'll wrap. Thanks a lot, guys. Really appreciate it.
Thank you. Have a great day, guys.
Thank you.
Thank you.